Hello, and welcome to the Chest Journal Podcast, where each month we host a discussion with the authors of important articles from the current issue of the journal, adding context and commentary to the challenges facing clinicians in the fields of pulmonary, critical care, and sleep medicine. To introduce today's topic, here's your host, Dr. Matt Siuba.
Welcome, everyone, to another edition of the Chest Journal Podcast. My name is Matt Siuba. I'm a medical intensivist at the Cleveland Clinic in Cleveland, Ohio. Today, I have the distinct pleasure to talk about an article that will be in the journal this month called Artificial Intelligence-Based Echocardiography and Pulmonary Arterial Hypertension. I'm joined here with the first author, Dr. Bettia Celestin, and the senior author, Dr. Francois Haddad. So first of all, we'll just get to know each of our authors who are with us today. Thank you both for being here. Bettia, why don't you start us off? Tell us a little bit more about yourself.
Hi. So thank you for having us first. So I'm Bettia Celestin. I'm a MD. I'm a cardiologist from France. I also have a master's degree in biostatistics. So I work at Stanford in research study in general, and in a PhD study with Dr. Francois Haddad, who is my mentor. And it's a pleasure to be here today. So thank you for that.
Thank you. Francois?
Yes, no, thank you for having us. It's a pleasure to be here. So I'm a cardiologist at Stanford, and I direct the biomarker core lab and imaging core lab, mainly specialized in pulmonary hypertension and imaging. And it's been really a passion, I think, in the last few years to really focus on early detection of disease and finding ways to really improve our diagnostic and minimize our errors in diagnosis.
Fantastic. Thank you both for being here. I'm also a pulmonary hypertension right heart enthusiast, so we're all kind of kindred spirits today. So I'm really excited to get into this conversation. To start, Bettia, tell us what inspired this study question.
So I think there's like a lot of things that we can have from the artificial intelligence, and it's really something that have improved like this last couple of years, decade, and that in medicine we have a lot of application that we can use in like a clinical routine, and that can help physician for early diagnosis, but for like every day like routine and follow up of a patient. So what brings us here is that this study is really something that we was really excited to do, because we wanted to see how we can apply artificial intelligence in the practice in detection of pH, and how it works, and how we can have enough confidence when we use this type of new technology. So that's how we find this really interesting, and we really wanted to run this study with Francois.
Fantastic. So to get into some of the details of this study, so to help the audience understand, Francois, there's a lot of technologies that fall under the umbrella of artificial intelligence. And in this study particular, we're talking about deep learning. Could you describe in general what deep learning is for our audience?
Yeah, no, that will be a pleasure. Maybe I want to add just maybe a small comment how the study got started.
Absolutely.
Because I want to give credit also to, so we were at the the discussion forum, which was really interesting with, actually Johnson & Johnson was there at discussion forum. It started with a general discussion of how is technology evolving? And people wanted to address really one important problem was misdiagnosis. We see that a lot of people with pulmonary hypertension, unfortunately, get diagnosed sometimes between 3 months to 18 months from their first symptom, and diagnoses are often delayed. So it got people thinking, can we improve it using better automation or better analysis of either electrocardiography or echocardiography? And that led to the that really led to the momentum of the study. And this came in through a forum with Johnson & Johnson that actually sponsored collaborative agreements to to really help move these studies. And from ultrasound to AI it started with a hub and Johnson & Johnson, and they moved really fast in the development with a very efficient system. So that's how it got started, the enthusiasm about the collaboration.
That's great. Thank you for giving us that background. That's really helpful to hear and to maybe inspire other people how they might similarly stimulate studies. To move into the question now about deep learning, could you describe that for our audience?
Absolutely. So sometimes we often hear the words artificial intelligence, machine learning, deep learning, and they sound alike sometimes, but they refer to different things. I think usually the big umbrella term artificial intelligence that we use is mainly based on rule-based reasoning or applying rules to solving a problem. Machine learning is usually more a term that refers to technology or algorithm that learn from data. I think at the most simple level, like classical statistic, like logistic regression that we use for diagnostic, is an example of machine learning. Other more complex tree-based learning algorithms are examples of machine learning. Deep learning learns more complex data. Often it learns data from at different layers, from more sometimes a basic layer that it learns really the most important features to the more complex layer, and that's why they call it deep learning, because often it involves several layers. And it really learns complex information, and it's able to reach a conclusion. Compared to machine learning algorithms, sometimes that conclusion is not always easily explainable, but can be, however, verified. So for this study, it was mainly the application of a deep learning algorithm that it learned how to analyze the images.
Thank you for that overview. That's really helpful. To delve more into the specifics, particularly like the software that we're using for this study, it's called us2.ai. Bettia, how does this software work? And could you give us some idea how long it might take to analyze images for echo compared to something like let's say how long it would take a cardiologist to read it?
Yeah, sure. So it's a platform. So it's when you take the images, you need to upload the images on the platform. But I think like in a lab, like a routine lab, it will be much easier to install this kind of platform, because it will be like directly connected with the images and the different study of the patient. So once we have the study on the platform, the deep learning, it's really super fast to read all the images. For this kind of deep learning, they have of course what we call the image view recognition, so identification, the different view identification, and after the different measurement. And this could be really fast, maybe less than 5 minutes for a really normal study, and could be just a little bit more for more images and more complicated study. And you have the different measurements. It's the EF, but this study is more on the right heart. So you will have the FAC, you will have the TAP CM mode. So the different measurements that we do in a routine lab, and you will have a report. And the report will give you the different measure, but also a conclusion about the study of the patient. And so it's really fast. It's easy to use. And after, of course, you can modify. So that's the really important point, is if you not agree with the tracing of, for example, your area, you can modify it, and you will have an adjustment of the measurement.
Thank you for that overview. Francois, anything to add?
Yeah, the idea. It's what's amazing about the ultrasound 2AI, just maybe history wise. I remember they came to visit Stanford. Carolyn Lamb, which is a cardiologist focusing on heart failure. Her husband James Hare, that did his master's also at Stanford. They came in, and actually it got started in I think 2017, but they progressed really fast in that technology. some really aspects to add to. So, for example, for the right heart, it was trained with approximately 5,000 images, and that's how it was able to develop its algorithm. When we're talking about deep learning algorithm, that's how it was. It led to the development of the segmentation algorithms. So one thing that's very important in the algorithm that we used, there's segmentation-based algorithm, meaning that when an image, like Bettia said, are uploaded, the system then can analyze them and segment every image. First, recognize the view, then really segment the image to divide it by the right ventricle. Usually it's based on area measurements or linear dimension or point estimates. And then a very important part of any algorithm that people develop is really internal quality control. Because you could segment any image, but if you don't have any internal quality control, then users, physicians, sonographer will not trust it. So that's a very important part of any software, any company that would develop needs to have.
Yeah, thank you. As you both are talking about this, it's really interesting to think about how this could potentially make routine echo lab acquisition a lot easier, and particularly for people like us who are interested in pulmonary hypertension, make sure those right-sided measurements are being appropriately emphasized and captured. So now that we have some sort of stimulation for why we might want to learn more about this, Francois, could you tell us about the basic overview of the study design for this paper?
Yeah, no, absolutely. With great pleasure. One thing is when we did this study, it wasn't connected on our server. So we actually, the first question we had to do, so the question we wanted to answer with Bettia was, is the ultrasound to AI an example of deep learning platform that's automated? Is it reliable for clinical use? So really that was the main question we wanted to answer. And we knew it, like you said, we knew it was important because one, we had a lot of misdiagnosis. And what physicians, sometimes we do estimate pulmonary hypertension and tricuspid regurgitation velocity in the European Society of Cardiology and ERS and the World Symposium. The algorithm for detection of pH really relies on peak tricuspid regurgitation velocity. But a lot of other information is available in the echoes that are often overlooked because we're busy. For example, the pulmonary flow can sometimes, even though acquired, can be overlooked and not measured. The shape of the right ventricle, the right atrial area, the shape of the septum, which really can give us a lot of insight whether there's pressure overload of the heart, are often overlooked. And this is where I think an automated algorithm can shine, where it could measure all automated and provide it to the to the user. One thing very important, you asked me about the study design. So when we spent several weeks to months developing the study and asking really the right question. We called it with Bettia implement right. And I think we have many questions before we design this. First of all, do we want to do a prospective or a retrospective study? I think in any technology, like a deep learning technology, we sometimes want to jump on the clinical application right away. But I think one important question is really the variability of the measures. And this is where the study first started, is can we really quantify the variability of the measures and how to design it properly? I don't know if Bettia wants to comment. We did something special in the study, like a triangular way of looking at variability. And I don't know if she wants to comment on that. We didn't just leave it to the deep learning and one reader. So she probably has some very good insight because she played the key role in designing this.
Yes, thank you, Francois. So yeah, I think the most important question is what Francois really said previously, like how we can rely on this kind of new technology and how it can help, but how we can rely on less. And how we started is really to make sure how we can try to assess how it's accurate and how we can assess the variability between readers, because the platform, so the AI here is another reader. So the goal is to compare different readers. So the reader 1, the reader 2, and the reader 3, for example. That will be AI. And so we did like an internal reading with Francois in the lab and the whole team, because of course there is a whole team behind that. And we compare with the AI platform and see how we can assess the variability and how it can be accurate. And this is how we design the study. We use a case control cohort, but also a referral cohort to compare the different measurements. And it's the way that we design this is really to try to measure how robust the measures are, and if there is any bias in the measurement for the AI platform compared to like normal reading or clinical reading or sonographer reading.
And like the first question we asked, apart from designing and choosing the cohort, so there's a difference between, like Bettia said, a case control cohort versus a referral cohort. So here we didn't select the cases. We took all comers. We wanted to make sure we had really variability of study quality, not only good quality studies really that went from poor to good. We also wanted to make sure we had a variability in the severity of pulmonary hypertension in designing the study. And this was really an important part in really selecting a correct population. A very other central aspect was making sure that it was really an external validation. Any technology, it has to really be an external validation to test the technology. And then we divided the questions really into three. The first one was what's the measurement yield of the technology? How many times it will lead to a measure? The second one was what's its variability? Does it have bias? What's its percent? Is it precise or is it biased? We wanted really to answer this analytic variability question. And the third one that is very important is really what's the clinical difference? Is it able to discriminate cases from control, not only in the case control study, but really in the referral cohort? And that's a very important distinction.
Absolutely. Thank you for taking us through that overview. And it's interesting to hear about the sort of three-way design to assess the quality and the precision of the studies. So now that we understand what you set out to do, Bettia, what were the key takeaways from this study?
So I think the key takeaway is that it's a promising technology that we can use, but of course that we need to check as physician in the lab, in the echo lab. We saw that, for example, for measurements that are like pulmonary, like tricuspid regurgitation, the right atrial area, for the TAPC MOD, that we had really good, accurate measurement between the different readings, so the AI reading and the clinical reading. So this kind of measurement, we can rely on them. Of course, with every time that we do any assessment with control, for more area measurement for the RV, so for the RV FAC, for example, we have more, the bias was higher, because it's harder to measure, even for a clinical and someone really experimented, in a clinical setting. So for this kind of measurement that needed more assessment from more clinical perspective, we can less rely on AI, but they still help us and discriminate with a really good significant result, the PH patient. So yeah, the main thing that we can say is we can really have a hope of increasing how we use this technology, but we can already rely on them for measurements that are more like easier to do in the clinical setting. For example, the peak TRV and the right atrial area or the TAPC. Maybe Francois, you have more to say about that.
No, I think you said it well. I think the first question is really which measurements. It's actually we when we start something, we don't know where it takes us, and this was this kind of study. So to do that, we developed new software to really look at laboratory variability, which we hope to continue working with Echo Society to implement. But the first key takeaway is some measurements are very reliable and have less variability, not because of deep learning necessarily, but even variability between two readers like me and Bettia. We had some variability, and that's important to pause before. We often think we don't have a lot of variability, but even between us, we do. But the measurements like the peak TRV, RV basal diameter, TAPC, and the right atrial area were more reproducible, both by the bias and the precision measures. Precision is more, bias is more describe the central tendency, and precision describe how do we vary across, apart from the central tendency. So both metrics are important for quality, and those four had really good measures. The areas had good precision, but there is really differences between readers. And working with, we started after this study an RV network group with many colleagues across the world, in Canada, in the US, and in Europe. And Harry and David Oxborough led to Maguinea. Really what's important, that we came up with an acronym that we hope will be used in guidelines called viewpoint. How do we measure it depends on your viewpoint. How can we measure reliably if we don't specify what's the best view? What's the best phase that you need to choose? What's the best interface? Do you really need to average measures? And how do you index or scale measures when you want to measure? So this study led to that actually also, because we step back and we say, how do we really make sure that all different readers standardize themselves?
Yeah, that's a really interesting question. And it's interesting how we started with this question specifically about artificial intelligence and then extend it to how do we standardize the process of echocardiography in the first place? And I think we've had similar conversations about right heart catheterization and pulmonary hypertension. So really interesting, and a lot of ongoing and future work that we could think about. Before we get to sort of future directions, Francois, what words of caution do you have for readers in interpreting these results in terms of what limitations may be present?
No, I think the first thing to remember is when we design a study for testing a technology, having an external validation is essential. The second part that's really essential is when you want to test the clinical difference and the implication clinically, it's important not to test it in a case control setting where we have people that are normal and patients with pulmonary hypertension. It's always going to look good. In many cases, I think it's important to use it, to test it in a referral based, where we have really a true case where people could have comorbidities or other conditions that may influence the quality. A word of caution is like everything. I think it's important. I think more when we rely on multiple metrics instead of just one, we improve quality for clinical use. Like here, if we don't have concordance between different measures of size, then we have a caution of whether we need to rely on this measure or not. And I think that's the most important thing. It's really an ensemble method or a global assessment that becomes very important for probability of disease.
Absolutely. Bettia, anything to add?
No, I think Francois really summed up it really well. It's exactly what we need to be careful about, that we have a case control study cohort here, but also referral. That's why it was important to add this referral cohort. And it's the limitation. It's about also the quality of the images, and we know that when we have like patient in the hospital and in the routine clinical setup, we have more like images that have less good quality that we can have when we do study sometimes. And that's a point that we have also in this study, that we also measure the variability with AI and the clinical reader among the different quality level of images.
I think what Bettia just said is a very important point, is that's something that's missing in a lot of echo reports, is we don't often indicate the level of quality of the signal we're referring to. Now, a lot of laboratory will say, is the peak TRV reliable or not, or is this measure reliable or not? This is something that hasn't made it yet in routine reporting in several of imaging labs.
Yeah, that's a great point. And I think that's something that we don't see enough unless you look at your own images. It'll be very difficult to tell. Bettia, what do you think are the next, now that we've seen some promise here, particularly for some of these longitudinal right ventricular function measures and TR velocity, what do you think are the next steps to assess the viability of this technology on a broader scale?
So I think the next step will be to have more prospective cohort study. So, for example, like we have patient coming and we do the ultrasound, and after we just use the platform, the deep learning, and in parallel we do also, of course, the clinical reading that we do routinely. And after we compare, once we finish, it's maybe the next step. I think prospective is always another way to go when we want to go further. And maybe the other step for this kind of technology is to apply in different, it's not just pH in different severity of pH, of course, but also try to like see in other diseases, complex heart diseases. I'm thinking about, for example, the pediatrics. So it's another way to assess like imaging that could be difficult. So yeah, I think there is a lot of things to do. So yeah, that's promising. I think really promising.
Great, thank you, Francois. Any last words?
No, I completely agree. I think the testing at the use cases is the most important thing, both for detection or prognosis or longitudinal monitoring. I think that's going to be the one very important aspect. The other exciting or interesting aspect is really combining different technologies. Like how does electrocardiography can be combined really with echo and combined with biomarkers and simple biomarker to really improve our yield in practice. I think that's important. Maybe one last comment. When Bettia was saying also early on, we tested an early version of the software, and then we recently retested a newer version, and there's an improvement. For example, analysis of the whole images can be much faster. The work, like 30 seconds to a minute, often can be done at the same time as acquisition. So that part has improved and is much more efficient than the earlier version, which is great for practice.
Thank you. Yes, this is a really exciting area of inquiry here, and I think there's major implications for the way that we detect pulmonary hypertension and take care of these patients. Thanks to everyone for joining us today to discuss this article, Artificial Intelligence-Based Echocardiography and Pulmonary Arterial Hypertension, with Drs. Bettia Celestin and Dr. Francois Haddad, and we will see you all next time.